So today we are going to talk about portal hypertension. Portal hypertension is defined as the elevation of the hepatic venous pressure gradient more than 5 mm of Hg, HVPG, hepatic venous pressure gradient. Right now, what is this hepatic venous pressure gradient? This hepatic venous pressure gradient, it is the difference in the pressure of portal vein and the inferior vena cava. So portal hypertension is a very important complication of cirrhosis which we should know, and it leads to certain other complications. So it is very important for us to know what is portal hypertension. Hypertension means increased tension in portal vein. So let us see the physiology. We have already dealt with this physiology in the regular classes as well. So focus, students, right? Please focus here. Here is the pen. Here is the pen. So we know that this liver, the liver receives blood supply from two sources, right? Blood flows into the liver from two sources. In this photograph, only one source is given, right? So one source is through the portal vein, although it is a vein, but it supplies blood to the liver, right? So blood from the inferior mesenteric vein and from the splenic vein, right, and from the gastric veins, right, it comes, then it forms the portal vein, the hepatic portal vein, right, and that from the portal vein the blood enters into the liver, right. Also there is one more supply of blood into the liver via abdominal artery. There is abdominal artery running parallel to this inferior vena cava, right, and from that abdominal artery the blood is entering into the liver via hepatic artery, right. So hepatic artery and portal vein are giving blood to the liver, and that blood from the hepatic artery and from the portal vein, it mixes in the sinusoids in the liver. In yesterday's lecture we have talked about this. It mixes in the sinusoids in the liver and it leaves the sinusoids as hepatic veins, and these hepatic veins join to form a common hepatic vein, and that hepatic vein drains blood into inferior vena cava, right. So that is the normal dual supply of liver, right. Now what is portal hypertension? Whenever there is hypertension in this portal vein, right, then we call that as portal hypertension. Basically the definition is, it is the hepatic venous pressure gradient, that is the difference between this portal vein and inferior vena cava. The difference in the pressure gradient of inferior vena cava and the hepatic portal vein is portal hypertension, right. H P V G, right, HPVG, right, HPVG, hepatic portal venous gradient. So whenever this portal vein is having more pressure, what will happen? The normal blood flow is from here to here, right. You can see the normal blood is flowing from inferior mesenteric vein to the portal vein and to the liver, right. So whenever there is portal hypertension, right, so there will be a backflow of blood. The normal flow will be obstructed and there will be a backflow. There will be a pathological backflow of blood. So what will that do? So pathogenesis. So now why this portal hypertension has developed? This portal hypertension can be caused due to prehepatic causes, hepatic causes and post-hepatic causes, right? Pre-hepatic causes like portal vein thrombosis, portal venous thrombosis, splenic vein thrombosis, or splenomegaly. Hepatic like pertaining to liver like cirrhosis, alcoholic hepatitis, malignancies. Post-hepatic like hepatic vein obstructions, most common inferior vena cava obstructions or congestive heart failure. Now, the this is our portal vein. Why it will be having a raised pressure gradient, while why it will be having a hypertension? Because of the pre-hepatic causes, hepatic causes, and post-hepatic causes. So these causes here are pre-hepatic causes. The causes here are hepatic causes, and the causes post to the liver are post-hepatic causes. So these are post-hepatic causes, right? And the causes here are pre-hepatic causes. Pre-hepatic causes, right? Pre-hepatic causes. This is pre, right? R. So pre-hepatic causes. So pre-hepatic causes like portal vein thrombosis. If there is a thrombus, say there is a thrombus here, or there is a thrombus here, right? So if there is a thrombus here, there will be backflow of blood, the pressure will increase, that will lead to portal hypertension. Splenic vein, right, like this is spleen. So splenic vein thrombosis, if there is a thrombus here, or portal vein thrombosis, so any reason which is pre to the liver could be the cause for portal hypertension. Similarly, if the liver is having some abnormality, for example, yesterday we talked about the cirrhosis, right? So if liver is having cirrhosis, right, cirrhosis. So cirrhosis, if liver is having cirrhosis, what will happen? We have learned that cirrhosis is the formation of fibrous bands, right, and hepatic regenerative nodules. So the portal, the fibrous bands could be including the portal system. The the portal vein could be surrounded by the the portal vein could be surrounded by the fibrous bands, or the overall sinusoids will be having fibrous bands around them, obstructing the flow of the blood through the sinusoids, through the liver. So if there is obstruction, because of the cirrhosis, there is obstruction of blood flow. So there will be obstruction of blood flow from the portal vein, right? Because there is fibrosis, right? So there is no normal blood flow is obstructed, that will lead to a backflow of blood, and which will cause portal hypertension. So cirrhosis is one very important cause for portal hypertension. Similarly, if there is some obstruction in the hepatic vein, suppose hepatic vein is having a thrombus, or hepatic vein is occluded because of some syndrome called as Budd-Chiari syndrome. Because of Budd-Chiari syndrome, this hepatic vein is occluded, it is narrowed, it is stenosed. Then it can lead to a backflow of blood, right, to the portal vein, causing portal hypertension. So pre-hepatic causes, hepatic causes, and post-hepatic causes can be the reason for portal hypertension. See, post-hepatic causes like inferior vena cava obstructions, like hepatic vein obstructions, Budd-Chiari syndrome, right? Congestive heart failure. If there is congestive heart failure, then the blood will not flow from the inferior vena cava into the heart, leading to a backflow of blood to the liver, leading to portal hypertension. Similarly, hepatic causes, if the blood flow through the liver is not proper, mainly because of cirrhosis, malignancies, right? So increased, what is the pathogenesis? Increased intrahepatic resistance of the passage of blood flow of the liver through the liver due to cirrhosis, right? Or it could be due to increased splanchnic blood flow secondary to vasodilation. So what will happen? This splanchnic blood flow, the blood flow through the inferior mesenteric artery, or blood flow through the splenic vein, or this gastric vein, right, or superior mesenteric vein, the these vessels, they may dilate because of the hepatocytic injury. Suppose if liver is having liver hepatitis or cirrhosis, then because of the generation of the certain chemicals, these veins will go into vasodilation, and that will increase the splanchnic blood flow. So blood flow from here will increase to the liver, whereas the liver will not take the blood because of the, say, hepatitis or because of the cirrhosis, right? Because of the congestion in the liver, right? The blood will not flow properly, and that will lead to portal hypertension. So second is splanchnic blood flow, increased splanchnic blood flow because of the vasodilation, right? So these could be the causes for portal hypertension. Now, portal hypertension results in primarily three complications: varicose bleeding, ascites, and hypersplenism. We already know about the varicose bleeding, that portal vein gives a branch which is called as gastric vein to the gastroesophageal junctions, and from these gastroesophageal junctions, whenever there is increased portal vein pressure, right, hepatic portal venous gradient is increased, portal hypertension is there, it will lead to the formation of varices, right? Varices, the swellings in the esophagus, and ultimately they can lead to blood into the esophagus and into the stomach, and from the stomach it is vomited out, which is called as hematemesis, right? So varicose bleeding is very important complication. The person might die because of this complication. Second is ascites. So now, because portal hypertension is there, there will be a backflow of blood, there will be congestion of blood in the portal vein, and that congestion will lead to the oozing of fluid into the peritoneal cavity, and the excessive fluid in the peritoneal cavity will cause ascites, right? Say this ascites, right? Also, we will talk about this ascites later, right, in the coming slides. So patient will land up into ascites. And third is hypersplenism. The spleen will be increased in size, right? So these are the three main clinical feature investigations. Portal hypertension can be easily detected in an ultrasonography, right, USG. More important is more accurate is Doppler ultrasonography, right? Doppler ultrasonography tells us about that the portal vein is having hypertension. So now we are going to talk about the ascites. So portal hypertension can lead to increased backflow of blood into the splanchnic circulation, and from those splanchnic blood vessels, the fluid, the water can ooze out into the peritoneal cavity and can lead to the excessive amount of fluid in the peritoneal cavity. So excessive amount of fluid in the peritoneal cavity is ascites. Hydroperitoneum, right? So a person looks like this, a person with ascites looks like this, right? So the definition is accumulation of excessive fluid in the peritoneal cavity, right? Peritoneal cavity is having fluid approximately 50 ml in the normal physiological conditions, but when it increases to more than that, more than 50 ml, we call that as ascites, right? Clinically, we can detect as low as 500 ml, right? It can go to various quantities like 4 liters, 5 liters also can be accumulated in the peritoneal cavity, right? So when 500 ml of the fluid is there in the peritoneal cavity, the person might be unaware of that condition, but you can clinically detect that by doing certain percussions. We will talk about those clinical methods in the clinical classes. Now, what are the causes of ascites? Very important ascites. You have to remember the causes, because whenever a person with a big abdomen and having water inside walks to you, you have to remember the main causes for that. So main causes for ascites is CCM, cirrhosis, right? Cirrhosis of liver. Second is cardiac failure, congestive cardiac failure, that can lead to the backflow of blood, right? Congestive cardiac failure will lead to the backflow of blood into the inferior vena cava, especially if it is right heart failure, and from the inferior vena cava it can lead to portal hypertension, which can lead to ascites. So Then third is malignancy. So cirrhosis, cardiac failure and malignancies are the common causes. Apart from them, there could be infectious causes like directly infection of the peritoneum. If there is infection of the peritoneum, then also it can lead to ascites, peritonitis, tuberculosis of abdomen, pancreatitis, right? Hypoprotein conditions, hypoproteinemias, when the person is having hypoprotein conditions, when the albumin and other proteins are less in the blood. For example, in the cases of malnourishment or in the cases of chronic liver diseases, when the liver is not producing enough albumin. So in hypoproteinous conditions also the person could be having ascites. Then hepatic venous occlusions. The hepatic vein, if a hepatic vein is occluded, if a hepatic vein is having is obstructed, for example in Budd-Chiari syndrome, then that can also leads to ascites. Lymphatic obstructions can definitely lead to ascites and other edemas, right? So pathogenesis is not very much difficult to understand. The There is water retention, right? There is water retention because of the portal hypertension. There is water retention in the third space in the peritoneal cavity, right? And also because of the vasodilation, the splanchnic vasodilation, right? The chemicals released by the dying liver cells, they leads to vasodilation of the splanchnic vessels and also the vasodilation of the afferent arterioles, the vasodilation of the renal arteries. So that will lead to excessive amount of sodium and water retention, right? And which leads to increased perfusion pressure of the capillaries, which leads to the oozing of fluid into the body, right? For example, this oozing of fluid into the body, in the legs it will cause edema, in the peritoneum it will cause ascites, right? So extravasation of fluid into the abdominal cavity leads to ascites. The major pathological feature or major pathological step is portal hypertension. So then clinical features. So first very obvious clinical feature is distended abdomen, right? So distended abdomen, if abdomen is distended, then the umbilicus will become everted, it will come out, right? Like a pouch, like a balloon, it will come out. Then second is orthopnea, because there is so much fluid in the abdomen that it elevates the diaphragm and the person has difficulty in breathing. And also because of this also because of the fluid below the diaphragm, it will lead to the oozing of fluid through the diaphragm and directly into the pleural cavities, causing pleural effusion. So pleural effusions could be there, or because of pleural effusion the person could be having breathing difficulties, right? Orthopnea, right? Whenever the person lies down, the difficulty in breathing appears because of the diaphragm, because of the fluid, excessive fluid below the diaphragm. Gastroesophageal reflux is also very common, right? It's a common feature. Whenever a person is having ascites, the person could be having gastroesophageal reflux, the hyperacidity trouble, right? And other signs of cirrhosis, which we have already talked about. The person could be having jaundice if it is cirrhosis, or if it is some other chronic liver disease. Person could be having jaundice, fatigue, malaise, cachexia, and other, right? Caput medusae also, right? There could be caput medusae also. Patients with massive ascites are often malnourished. They will be thin and emaciated, just like in the previous picture. You can see the person will be thin and emaciated, and they will be malnourished. Muscle wasting will be there. Excessive fatigue and weakness will be there. The diseases which I have been taking in these lectures, they are very important because these patients walks into an Ayurvedic OPD very often. The patients with ascites, the patient with liver diseases, they walk very often into the clinic. So you should know about the disease first before treating them. Right. So investigations, ultrasound or CT scanning tells us about the exact amount of fluid in the peritoneal cavity. The liver function test will be deranged because, yes, they will be deranged because the prime cause of ascites is cirrhosis, right? So what we do is we with the help of a syringe, we take little fluid from the peritoneal cavity and we evaluate that fluid, right? We evaluate that ascitic fluid, right? So this is a diagnostic paracentesis. We have a therapeutic paracentesis also, where we drain this fluid with the help of a drip. With the help of needle and a drip, we drain this fluid from the abdominal cavity. So that is therapeutic paracentesis. But for diagnostic paracentesis, we take little amount of fluid, 5 to 10 ml, and we evaluate that fluid for 5 things. Very important, you should remember that these five things. First is proteins, the protein content in the ascitic fluid, the albumin and the globulin and other proteins in the ascitic, or the total proteins in the ascitic fluid, especially the albumin. So second is albumin content, then the blood count, the complete blood count, and also the differential blood count, also the differential of it, right? TLC and DLC, both differential count also and total count also. Complete blood count we will see. We will try to find the erythrocytes in this, we will try to find the WBCs in this, and we will also try to find the count of WBCs in this. Then amylase levels in this, because if this ascites is because of the pancreas, if it is because of the pancreatitis, then the amylase levels will be raised. And fifth is culture. We will do the culture if it is because of some bacteria, for example peritonitis, right? Infection of the peritoneum. If it is because of the infection, then we will get to know because of the culture. We will try to culture it to find any bacteria in it. So always remember, whenever you will do a diagnostic paracentesis, you have to send the ascitic fluid for the evaluation of protein, albumin, CBC, amylase and culture, the very basics. Apart from this, if the patient is having features of tuberculosis, then you have to send the ascitic fluid for tuberculosis evaluation also, by determining the ADA levels, adenosine amine levels also you have to find out, right? If it is because of if there are some features of the abdominal tuberculosis. Then this ascitic fluid is labeled as exudate or transudate, right? Exudate or transudate. Now what are these exudates and transudates? Exudates are the ascitic fluid is labeled as exudate when the total protein levels are greater than 2.5 grams per dl, and it is called as transudates when the protein levels are less than 2.5 grams per dl, right? So this exudates, basically the exudates are because of the infections and the malignancies, right? If there is infection or malignancies, the fluid is mostly exudates. The causes of exudates are infections and malignancies. And transudates, mostly the cause is portal hypertension. Because of the portal hypertension, and the causes of portal hypertension will lead to transudate fluid of ascites, transudative fluid of ascites, or ascitic fluid will be transudate in origin. See, these exudates are infectious or malignancies, so mostly they will not be having transparent color. Mostly they will be having some brownish color or some yellowish color, or if it is malignancy, it could be having reddish color because of the blood, right? Whereas transudates are mostly transparent, little bit transparent, translucent in color. So by looking also at the fluid, you can say it is infectious cause or it is a portal hypertensive cause. In portal hypertension, it will be mostly transparent in color. So now this transudate and exudates are the things of past. Now we define the ascitic fluid into serum ascites to albumin gradient, SAG. SAAG. So serum ascites to albumin gradient is called as SAAG. This serum ascites to albumin gradient is measured by subtracting the serum albumin levels by the ascitic fluid albumin levels. So we send the ascitic fluid for albumin levels, and we send the blood serum, the blood for albumin levels, and we subtract both. Suppose if the blood serum level is 4 and the ascitic fluid level is say 3, so 4 minus 3 is 1, right? So we try to find out the SAG level by subtracting both the albumin level. So if SAG level is less than 1.1 gram per deciliter, then the causes are infectious or malignancies. That is, the ascitic fluid is an exudate. and when SAG is greater than 1.1, then the serum albumin is more than the ascitic albumin, right? See, SAG score is more than 1.1, then the causes are portal hypertension. So this is more accurate and this is more latest, the SAG score rather than transudates and exudates. So this SAG score or transudates or exudates, they help us to find out the cause for ascites, because whenever a person walks into the clinic with ascites, we have to find out the cause. What is the cause? Whether that cause is because of the liver, right, like cirrhosis, like malignancies, or whether that cause is because of the heart, like congestive heart failure, or whether that cause is because of the infection, for example peritonitis, for example pancreatitis, or for example some tuberculosis infections. So based on the investigations, we can find out the cause. For example, if the color of ascitic fluid is straw yellow, right, it is yellowish color, and the proteins are less than, the total proteins of the ascitic fluid are less than 2.5. SAG score is greater than 1.1. The WBCs in the ascitic fluid are less than 250 and there are no RBCs, then the cause is very obvious, cirrhosis. Right? Congestive cardiac failure, the color will be clear, it will be transparent, translucent, or little yellowish. The proteins will be 1.5 to 3.5. SAG score will be greater than 1.1, right? And there will be no WBC and RBCs, then it is purely congestive cardiac failure, right? Congestive cardiac failure leads to very transparent ascitic fluid. Then malignancies, the color will be hemorrhagic, it will be bloody. Proteins will be greater than 2.5, SAG score will be less than 1.1, and there will be huge amount of RBCs and WBCs, right? Similarly, if it is bacterial, the color will be purulent, it will be like the color of the pus, dark yellow color, and proteins will be greater than 2.5, SAG will be less than 1.1, WBCs will be greater than 1000, there will be in huge amount, and RBCs will be absent, because in bacterial there will be more WBCs, right? Similarly in tuberculosis, there will be more bacteria, there will be more WBCs, there will be proteins will be greater than 2.5 and the SAG score will be less than 1.1, and the color will be turbid or yellow. So based on the ascitic fluid ascitic fluid lab features, lab values, and the color, we can suspect the cause, or we can diagnose the cause. Then what are the complications of ascites? Ascites can lead to further peritonitis, the infectious peritonitis, that is spontaneous bacterial peritonitis, right? And it can lead to the pleural effusions. The fluid from the peritoneum may seep from the, it may seep from the diaphragm to the pleural cavity and may cause pleural effusions, and that much is sufficient, right? That much is sufficient for ascites. So keep studying and keep studying.